John. And again, thank you to everyone for joining us this morning. I hope that's already been some very informative information, stuff to think about, maybe things to scare you. And hopefully we'll keep this train rolling with some more useful information as we talk about, like John said, kind of the lay of the land under, the COVID-19 pandemic a year or really a year and a half later. We've got some things that are fairly familiar to us by now. Everyone has got a significant amount of experience dealing with COVID over the course of a year and a half. I think we have a much better idea of how to treat COVID when people or patients contract COVID. We've got a vaccine now that is proven to be pretty effective at keeping people from getting COVID and very effective from keeping people from being hospitalized and having other serious cases of COVID. We've got COVID still. In some respects, things are the same. A lot of the same regulatory waivers apply. We'll go over that in a little bit. But in some respects, things are also very different as well. We've got kind of a new regulatory environment, new legal environment, and some new challenges as we deal with a new variant of COVID in the Delta variant. So we're going to cover all that. And if nothing else, we'll touch on all of the regulatory waivers that have been in effect since last year so that you can say that somebody other than you went and looked at it and confirmed that they're still in place. Before we jump into all that, just a quick look at the timeline. This is probably all too familiar for all of you, and trust me, I really don't want to be talking about COVID any more than you want to be hearing about it. I'm sure you're all tired of it, but let's take a look at the timeline real quick. Looking at the COVID-19 emergency declaration timeline, we've got a initial declaration by then Secretary Azar of HHS back in January of 2020. That combined with a declaration by President Trump under the Stafford Act in March of 2020 combines to give you some flexibilities under on the federal level under Section 1135 of the Social Security Act, which we'll talk about in a little bit. You can also see there at the same time President Trump was declaring a nationwide public health emergency. Last year, you've got Governor Ivey that declared a state public health emergency for Alabama under the Alabama Emergency Management Act of 1955. That's also very important as far as fully implementing the regulatory flexibilities that are available on the federal level, but also making sure you're consistent with state law requirements. Never mind John back there, we're going to figure out this battery issue, but until then, I'm going to keep on rocking along. March 17th, 2020, Secretary Azar makes a PrEP Act declaration, which gives you some liability and immunity protections. We'll talk a little bit about that later. And then, fast forward a year and a half, lots and lots of emergency declarations. All of those have a significant impact in one way or another. Fast forwarding a year and a half from last March to May of this year, we've got Governor Ivey signaling the end of Alabama's state of emergency declaration with her final state public health emergency extension of May 3rd. This was also the final safer apart order from State Health Officer Dr. Scott Harris. And that signaled the end of the safer apart order on May 31st and the end of the state public health emergency on July 6th of 2021. Fast forward, and I guess to make a point here, it was good that we had a long ramp down. We had plenty of signals that the public health emergency on the state level was coming to an end. Things were starting to get better. But by the time that the state public health emergency actually ended in July of 2021, things had already started to turn again. We started seeing a higher number of COVID-19 cases and higher number of hospitalizations, as you're all aware, dealing with the Delta variant. And all of a sudden, as soon as we have the termination of the public health emergency, we're right back needing one again. And it took a little bit of time to get a new public health emergency declaration as of August 13th, 2021. But fortunately, we did get that eventually. For the time between two emergencies, or maybe I should have used a Charles Dickens reference, A Tale of Two Emergencies. Neither one's really good, but at the end of that first state public health emergency, or PHE, even at the end of that on July 6th, we had continued federal public health emergency declaration. So we still had flexibility on the federal level under the 1135 waivers, which we'll discuss in a minute. But SHPTA had implemented some emergency rules and then modified its final permanent rules about temporary emergency CON waivers. Those waivers, unfortunately, were tied to the state public health emergency declaration, which makes sense. CON is a state law creature, not a federal law creature, so it makes sense to have those tied to a state public health emergency declaration. But at any rate, those waivers were going out the window. Again, we had a wind down period of 60 days after the end of the state public health emergency, so there was some time to unwind those arrangements. But at a time when Alabama and when our healthcare providers, our hospitals needed flexibility the most, SHPTA didn't really have any authority to issue new temporary emergency CON waivers after the end of the July 6, 2021 first state public health emergency. So fortunately, by August, middle of August, we've got Governor Ivey coming back in and issuing a new public health emergency declaration. All of a sudden, we've got SHPTA's authority kicking back in under the temporary emergency CON waiver rules. We've got the return of expanded scope of practice and expanded collaboration and supervision for advanced practice providers. And we've got licensure boards that had previously been reluctant to issue new emergency rules that now felt more comfortable with the public health emergency declaration in place. So again, we're going to look at sort of the continued flexibilities and the new challenges. What stays the same, what has changed over the course of the last year and a half dealing with the pandemic. This is a brief overview of everything that we'll cover. We'll go, federal level with the Section 1135 waivers. We'll look at the new Alabama Public Health Emergency Declaration and some of the administrative rules that have been passed or promulgated on an emergency basis since then. We will look at another familiar concept about alternate care sites that many of you probably utilized last year. So this will be just a quick refresher on the process for that and sort of what public health is looking for in order to approve those arrangements. Another topic that I think a lot of people have asked about or maybe even made use of is the concept of using emergency medical services personnel in a hospital setting instead of just in ambulance, paramedic, pre-hospital setting type situations. We'll take a look at that and a law that was passed this session that allows a broader use of EMS personnel. We'll look at requests for survey suspensions. Hopefully none of you are in your survey window right now, but if you're unfortunate enough to have that going on top of everything else, we'll look at some options to request a suspension of survey activity for you. We'll take a look at Alabama COVID-19 immunity protections very briefly, something I think Greg will cover in more detail later today. And then we'll look at some new legal challenges or maybe operational challenges caused by some new laws. As I mentioned, we kind of know things about COVID and how to respond to it. We've got a new weapon in the form of a vaccine, but we've also got new challenges in the form of vaccine mandates or maybe anti-vaccine mandates on both the state and the federal level. They're kind of at odds and I think are going to come to a head in the next couple of months. Also taking a look at visitation rights and then a quick look at provider relief fund reporting. So start out, let's do the easy stuff, the stuff that has more or less stayed the same over the last year. Section 1135 waivers, as I mentioned earlier, these are kicked into play when you've got an emergency or disaster declaration by the president under the National Emergencies Act or the Stafford Act, and a public health emergency declaration by the HHS secretary under the Public Health Service Act. We still have both of, still have both of those, and there's no apparent end in sight for that federal flexibility. So we're still going strong on that for right now. The purpose of the 1135 waivers, going back to what John said earlier, y'all are just the most regulated industry in the entire country. it seems, and there are so many regulations and requirements that are technical requirements, they are administrative burdens, and there's all kinds of things that if you're dealing with a pandemic in the face of emergencies and you're being overrun with patients, it may not be feasible to meet all of those technical requirements. So what the Section 1135 waivers do is they allow you to and incentivize you to continue to provide services in good faith and meet all the requirements that are not waived, but waive some of those more onerous requirements that are not as core or integral to the provision of healthcare services. And it allows you to get paid for providing those services, because we don't want our healthcare workforce standing down in the face of an emergency because they're terrified of what the government's going to do to them, when it turns out it's kind of hard to meet all the government's regulatory requirements in a pandemic. So anyway, we've got 1135 waivers. These include waiver of Medicare, Medicaid, and CHIP requirements, including conditions of participation, requirements of coverage, program participation requirements, requirements for licensure of physicians and other healthcare providers across state lines, a few limited waivers with respect to EMTALA, as well as some physician self-referral law or Stark law waivers and Hipaa waivers, which we'll touch on each of those about as quickly as I can moving through here. Starting out mostly with the condition of participation waivers for hospitals, and I'm trying to set these up side by side here so you kind of see what the baseline requirements are under existing law and what the current flexibilities are under the Section 1135 waivers. I will say I had to challenge myself to go back and look at the federal blanket waivers, and I did confirm that all of these are still listed in a federal waiver document. So, for instance, verbal orders, typically those have to be used no more than infrequently. Under the pandemic, you can use them more often, and you can authenticate verbal orders more than 48 hours after the verbal order was entered. So you've got a little more time to do that, realizing that patient care needs might take priority over ensuring documentation requirements. But I will caution that making sure you get things documented is still very, very important for liability purposes and all kinds of other reasons that we might get into some later. There are also some requirements waived, or procedural or administrative requirements waived for standing orders. Again, a lot of this is all available for you on the slides. We'll try and skim through it about as quickly as possible to get on to the more fun stuff. But patient rights, there's a lot of waivers with respect to the timeline for providing medical records to patients when they request access, some policies and procedures for visitation, and also issues regarding restraint and seclusion. Note that the waivers provided here are only in areas impacted by a widespread outbreak. We're a little bit behind time on where I thought I'd be, so I'm skipping right through some of the COP waivers. Again, remember, existing law on the left, current flexibilities on the right. I did go back and check these within the last week, so the current flexibilities are still available as of the time we're talking right now. Again, kind of moving along right through these medical staff renewals. This is something that'll come into play with some of the interstate physician licensure flexibilities that have been granted on the state side. If you've got some administrative problems getting through the formal medical staff credentialing process for physicians or other practitioners, let's say somebody is up for renewal and you can't get the renewal completed in time, or you're adding someone new to the medical staff and can't get them fully privileged in time during the normal process. All of those formal requirements for privileging and credentialing on the medical staff are waived, so that those physicians can go ahead and start providing services under a couple of conditions, as you'll see at the bottom there. Some of these relate to out-of-state physicians specifically, but they've got to be Medicare enrolled. They've got to have a valid license in the state where they're enrolled under Medicare as a provider. They must be providing services either in person or via telehealth to contribute to relief efforts in our state here in Alabama or another state. And they cannot have been affirmatively excluded in any state that's part of the 1135 emergency area. Note, though, that this does not waive state licensure requirements. You still have to comply with whatever your state's licensure requirements are, in this case, Alabama, and we'll talk about those in a little bit. Completion of medical records, long story short, you've got more time to complete them. Physical environment, this is a big one. We've got flexibilities that allow facilities that were not normally used for healthcare services or intended, for that matter, to be used for healthcare services. We're waiving a bunch of the technical requirements under the conditions of participation for those physical facilities to allow things like field hospitals or like converting an ASC into a hospital if you need that capacity to care for patients on an inpatient basis or other basis due to a surge in patients from COVID-19, which we've seen all of you deal with over the last month or so. That's going to be tied in with public health requirements for alternate care sites, which we'll talk about in a little bit. And this is somewhat similar to the information on the last slide, but keep in mind too that if you've got a new provider that you're enrolling for the first time, or if you're changing an enrollment, you still need to go through CMS's provider enrollment process to make sure that that provider is enrolled so that you can actually bill for and receive reimbursement for the services provided in that facility. There was some interesting discussion about the enrollment flexibilities that were provided last year to enroll new providers. Heard a lot of people with a lot of horror stories about the enrollment hotline and how it didn't really work, and a lot of the CMS or the MAC staff were not really familiar with what they were being asked to do because this was a new thing, a new environment, and new problems that we were dealing with. Hopefully those things have been smoothed out now, but at any rate, if you're enrolling a new provider, you should be able to do that faster than the ordinary process, which is somewhere probably in the 90 days to 6 months range. Billing, important billing flexibilities. So if you've got an inpatient psych unit that's a distinct part unit in your facility, and you've got to house those patients in a general acute care area of the hospital because you're using your distinct part unit as a COVID-19 isolation unit, you can do both of those things, and you can continue to bill for that patient under the prospective payment system that they fall under. So your psych patient that you move to a general acute care bed, you can still bill them as a psych patient. Vice versa, if you have a general acute care patient with COVID-19 that gets moved to your psych unit, which you are now using as a COVID-19 isolation unit, you can do all that and continue to bill for that general acute care patient as general acute care. A couple of things you want to check off the list. You want to make sure whichever bed you're using in whichever of those two scenarios we were talking about is appropriate for the patient. And that, for instance, if you've got a psych patient out in a general acute care unit, that you've got appropriate staff and appropriate equipment, facilities, protective measures to protect that patient. Because otherwise, if they're in the psych unit, as we all know, that they're pretty intensive requirements for ligature risk and other things, patient checks. So we want to make sure that the environment is safe for those patients, even though you're allowed to move them into another part of the hospital and still bill for them as a psych patient. Also make sure that you notate that in the patient's medical record and document the reason for moving the patients around. I'm assuming that these reasons would be something like patient cohorting, bed shortages, or similar things like that, but make sure you notate that reason in the medical record for those patients. Other billing issues, some medical necessity issues we ran into last year. Typically when a patient's no longer in need of acute care, you look to discharge them, in some cases to a post-acute care setting like a nursing facility. Well, last year at the height of everything, while we're still trying to figure everything out, you've got a good number of nursing homes that aren't accepting patients that were COVID-19 positive until they turn up 2 negative tests or there's a pretty good indication that they're no longer positive for COVID-19 and could spread it to the rest of the facility. This may not be as big an issue anymore, but note that if you're having trouble placing a patient post-acute and there are no beds available for that patient in a local post-acute care facility, that you can keep that patient in the facility even though they no longer meet the criteria for inpatient admission. As long as they need some post-acute care, you can kind of step them down until they basically meet the criteria for the nursing home to be admitted there from a COVID-19 and kind of infection control standpoint. and you will get paid the Medicare rate for the DRG and any outlier costs to the extent you keep that patient longer while they're being quarantined or isolated until they can be discharged to a post-acute care setting. There's also a couple of billing flexibilities for Alabama Medicaid. Those are available through some links there, as well as a note about the 20% increase in the hospital per diem rates. One note about things going the other way, going back to normal, Medicaid announced that effective September 1, 2021, EPSDT, or Early Periodic Screening, Detection, and Treatment, that's a mouthful. Those referral requirements for children under 19 to get specialty services are back in place now, effective as of September. So to the extent you've got pediatric patients referred for specialty care services, make sure you've got that EPSDT referral in place, or you will not be able to bill for those services likely. Still moving through COP waivers. Big point here as far as critical access hospitals, at least in my mind, is that CAHs are permitted to have more than 25 beds and greater than a 96-hour average length of stay during the pandemic. There's also some status and location flexibility as far as the rural areas and distance requirements, as far as the CAH being a certain distance away from any other hospital. Flexibility on that front too. Swing beds, I know a lot of you probably made use of swing beds last year and may still be making use of them this year to provide step-down care to patients, similar to that issue with keeping a hospital inpatient until they can be discharged to a nursing home. Many of you may have been able to use a swing bed to do that instead of keeping them in a general inpatient unit. Under one of the later granted federal blanket waivers, this one took a little bit longer to get. Typically a hospital has to have fewer than 100 beds and be located in a rural area in order to have swing beds. That's no longer the case under the federal blanket waivers, but you have to not use your SNF swing beds for acute level care. You've got to comply with the other conditions of participation and SNF requirements that apply to swing beds to the extent they are not waived. And you've got to use your swing beds consistent with your state emergency preparedness and pandemic plan. There's also some good information there about the MAC hotline and the enrollment process for getting swing beds if you have not had them before. And then a quick note that just like skilled nursing facilities, for swing beds, the requirement of having a 3-day prior hospitalization has been waived. We're going to skip over the long-term care facilities. I know a few of you have nursing homes affiliated with your organizations, but that's a little bit more of a tangential topic than we've got time to cover. EMTALA requirements, note that EMTALA is not full-on waived during the pandemic. There are certain things that you can do. For instance, you can refer individuals or direct individuals to another location to receive their medical screening examination. For example, if you want to keep them out of your emergency department instead of bringing more COVID-19 positive patients into it, that's something you can do, or just to generally relieve crowding in your ER. You can direct patients to another location to receive a medical screening examination. Catch there is, if somebody says, I want to be treated in the ER, you need to go ahead and provide a medical screening examination and treatment in the ER and not try and force them off to the other location. You don't want to get any EMTALA complaints against you by someone having a misunderstanding about what their options are to receive emergency treatment. So just be careful about that. You can redirect people, but perception and reality are two different things, and a patient who's dealing with an emergency situation may feel like they're being denied emergency care if they're directed elsewhere. So be careful how you phrase things. Moving along, Stark waivers. Not going to go into a whole lot of detail about this, but know that there are still Stark waivers in place. It's almost unprecedented to have blanket Stark waivers. Typically, you would have to apply for them individually and kind of state your justification for why you were implementing a waiver of the Stark law requirements. In this case, as we saw with the federal blanket waivers, it was such an administrative nightmare for CMS to try and keep up with just the blanket COP waivers that there's no way they could keep up with individual Stark law waivers. So instead, you've got blanket waivers to allow diagnosis and medically necessary treatment of COVID-19 and several other conditions or situations that arise out of the COVID-19 pandemic. And those allow you to waive things like the requirement to have fair market value rental, lease, and other payments, limitations under the exceptions for the Stark Law as far as medical staff incidental benefits and non-monetary compensation. You've got a lot of flexibility under the Stark Law, but as we were reminded in a recent national virtual webinar, everyone they need to be cognizant of their usage of Stark Law waivers and make sure that they are well documented as far as the reason for the waiver, the exact waiver that was being used, and then keep track of these things, because I know it doesn't seem like it right now, but one of these days we will be at the end of this state and federal public health emergency, I hope. And by the time the public health emergency ends on the federal level, we will be back to normal, and these arrangements that were set up under a Stark waiver will at that point in time either need to be discontinued or fit under an existing exception to the Stark Law with all the requirements being met. I've been going on for at least 10 minutes and haven't been shut down, so I'm feeling pretty good about this. We're going to keep moving along. Hipaa requirements, I'm not going into any detail there. None of these specific requirements were waived in the public health emergency declarations on the federal level as far as what I saw, but there are a good number of items of enforcement discretion that have been issued by the Office of Civil Rights and others, as well as plenty of flexibility under existing Hipaa regulations that allow you to make necessary disclosures in response to the COVID-19 pandemic. If you got any questions about that, happy to answer those offline since we're a little bit behind here. Moving right along to some of the things that are new or a little bit different, although they still feel familiar. Let's take a look at some emergency rules and Alabama's new public health emergency declaration. Under the declaration itself, we've got to return to a similar arrangement where hospitals can make use of a potentially unlimited number of advanced practice professionals under the collaboration or supervision of a single physician, in this case, the chief of staff or a medical director. That can be done under a standard protocol and formulary unless the nurse or advanced practice provider had already been approved for an expanded protocol or formulary. They can also apply for an expansion, except not an expansion of their controlled substances available under their formulary. For these advanced practice practitioners, there's no license fee, there's no application required to the Board of Medical Examiners or the Board of Nursing. You just have to verify the licensure, verify the practitioner's advanced practice approval and their certification. And here's the twist. We've got a slightly new requirement that got snuck into the emergency declaration from August 13th, a little bit later, that we were not aware of. And that is that there are some reporting requirements. The Board of Nursing and the BME want to know how you are utilizing this scope of practice and collaboration supervision flexibility under the public health emergency declaration. So as we'll see in just a second, I'll show you kind of an example of what the reports need to look like. Those are supposed to be done on a monthly basis, I guess, so that those two regulatory boards and licensure boards can keep track of what their licensees are doing. Standards of care, this is basically the same language that the prior public health emergency declaration from last year had. Basically, if you have implemented your emergency operations plan, the alternative standards of care that are listed in that plan or those plans apply, and those serve as the standard of care for your facility and for your healthcare providers, again, to the extent outlined in that emergency ops plan. And the PHE declaration from this August also directed SHPTA to actually authorized and directed SHPTA to approve temporary emergency CON waivers under its existing regulatory authority. And there is, I know it's a little bit fuzzy, but that's basically a clipping of what the reporting spreadsheet looks like for the information you've got to report on your advanced practice professionals that are operating under the waiver flexibility I just mentioned. This basically, I know you've got to report it to the board now, but that basically helps confirm your due diligence and that you checked off all the requirements that you were supposed to check off under the public health emergency declaration requirements. So there's an example of that. Quick note at the top there is you'll see, this flexibility is in place for 120 days without an extension, but if it's extended, you might see this carry on beyond that time period. Quick little bit about emergency rules that have been issued since the new state of emergency declaration. SHPTA does not have new rules. As I mentioned earlier, they had already put into place a permanent rule for temporary emergency CON waivers, and those rules are cited there for your reference. Basically, they were just directed to utilize that authority that they had available to them now that they have a new state public health emergency declaration. For the Board of Medical Examiners, maybe the key here is that you can get, a free, in other words, no license fee, license application fee, free expedited license for qualified out-of-state physicians and physician assistants to provide care in hospital inpatient units. That's a pretty important limitation. I think the Board of Medical Examiners has stuck by that limitation that this is only for practitioners that are providing care in inpatient units, ERs, and other acute care units, and that the level of, the type of care they're providing and to whom they're providing it is to patients who are suffering from and or affected by COVID-19. I think you can make a pretty compelling case that everyone is affected by COVID-19, but that's just a limitation to keep in mind. Board of Medical Examiners also expanded the number of physician assistants that a single physician can collaborate with or supervise. Supervise, I think is their terminology, from 4 to 9. That puts them on par with the other advanced practice professionals like your nurse practitioners, whose limit was expanded from 4 FTEs to 9 FTEs sometime in the last year or so. Things to note from this rule is that, this is a combined limit. So if you've got, 4 PAs and 2 nurse practitioners and a couple of other, what am I up to, 6, that leaves 3 more FTEs of any other type of designation. That's the total FTEs. You count them across all different APP specialties. So it's not 9 PAs and 9 nurse practitioners and 9 CRNAs. It's an aggregate limit, and this also applies across state lines. So, if you've got someone on the border that's collaborating with a few people in Alabama and also collaborating with a few people in another state, you've got to count the practitioners in the other states as well. And there are some reporting requirements for the collaborating or supervising physician to make sure they don't exceed those FTE limits. Board of Pharmacy has got, they're maybe the most prolific of the emergency rule proclaimers. As you can see right here, we're going to skip down to the bottom of those, maybe 680X2-0.47, allows offsite vaccine order entry for vaccines at the location or site where the vaccine is being administered. I can see that being useful for those of you that are putting on vaccine clinics, not just at your facilities, but in the community as well. We've also got some flexibility to allow patients to be discharged with certain medications. The only thing the rule mentions is metered dose inhalers, and then this kind of nebulous concept of other medications deemed necessary with Board of Pharmacy approval. So instead of wasting those medications and issuing a new prescription for the patient, those specific medications that are covered by this rule can be dispensed, and then the patient can be discharged with those meds in order to conserve, limited resources and medications. Also, you've got authority for pharmacists to issue a 1-month supply of patient maintenance medications under emergency circumstances where they can't reach a physician due to COVID-19. This rule does not include Schedule 2, so I guess that helps folks out with their maintenance medications while physicians and other practitioners are continuing to deal with new patients and new issues in the hospital. So at least that's a little bit of flexibility and continuity for patients as we try and keep them in stable medical condition and keep them from being admitted back to the hospital while you're dealing with intensive patient census numbers. This is just a quick look at the Board of Medical Examiners emergency application. It's, I think, a very abbreviated application compared to the normal licensure requirements. But basically logistics, if you're a hospital CEO and you've got a temporary physician coming in on an emergency basis, you're going to write a letter to the Board of Medical Examiners and say that this physician is practicing in my hospital and providing care to inpatients and emergency patients who are suffering from or affected by COVID-19. You and or the physician complete the expedited licensure application and submit it to the board. And I've got the, excuse me, the email address for submitting it right there. And supposedly they're doing this on a 48-hour turnaround basis. So it should happen fairly quickly. Authorized beds and alternate care sites is another fairly familiar concept with maybe a slightly different twist, or at least some updated guidance from the Department of Public Health. Start out with authorized bed capacity. Before we talk about that, I want to talk a little bit about some definitions that apply to your authorized bed capacity. You know, there are two different terms you need to keep in mind. One is your licensed beds, and the other is your authorized beds. Your licensed beds are the number of beds for which you have a certificate of need and are licensed by public health. Your authorized beds are the number of beds that you are actually staffing and have available for inpatient care. And as you can see there, you can have fewer authorized beds than you have licensed beds. The idea being that, you know, you've gone through a lot of trouble and in fact, probably a lot of legal expense to obtain a certificate of need for, you know, your licensed beds. And you may not at a particular point in time be able to use all of those beds based on staffing, equipment needs, other operational concerns. So your authorized bed capacity can be smaller than your licensed bed capacity. That's what you're actually going to put into play in your facility. And you can do that without relinquishing your CON for those beds. So I guess that's the concept there. As it relates to COVID-19, there is a process for hospitals to apply for an emergency increase in their authorized beds. And they can do that for the duration of the pandemic. There's a form, I guess a standard license application or license change application form that you file with public health. This form has been in place for a long time. It's not a new form you have to file, but public health is processing these without an application fee for right now. And you can submit a cover letter with your license change application to request expedited processing to bump up your authorized bed capacity up to the total number of your licensed beds as you struggle to deal with surge situations and heightened patient census, especially over the last month or so. A little bit different, alternate care sites. The thing I want to note about this, I know a bunch of you probably applied for and received approval for alternate care sites last year. My experience, which I can't say is too extensive with public health, but talking with them, they really, regardless of whether or not something is an alternate care site as defined there toward the top of the slide, they really want to know if you're making any changes to your licensed beds. You know, if you're moving ICU beds around or providing a new service or anything like that, that you're moving around to deal with surge capacity situations, they want to know about it because ultimately they've got the responsibility for approving the safety of these facilities, even though they may be waived on the federal level, excuse me. One of the requirements under those federal 1135 waivers is that the state survey agency, confirms that whatever requirements are waived, the facility still complies with basic safety requirements for the patient. So public health, there are a lot of things that are not an alternate care site. Public health still kind of wants to know about them. But to the extent you are setting up an alternate care site, for instance, a field hospital or turning an ambulatory surgery center into hospital beds, you file an application. You've got the link to the form there. It can be filed through Public Health's COVID-19 alternate care facility portal email address right there, and then it automatically gets forwarded to their legal department, I think Tony Dunklin and their provider standards department and a few others, basically everyone that needs to know about this application and weigh in on it. What they want to see is a short and clear description of what you're proposing for your alternate care site. They want to make sure that you've got a CON or a CON waiver for whatever you're proposing to do, or they probably won't issue the alternate care site license or approval. And then they want some technical services info to make sure, again, that you're meeting basic safety requirements to ensure the safety of your patients with respect to life safety code, fire safety code under the NFPA, and then to the extent applicable, depending on what kind of services you're providing, that you've got emergency generators in place in case something happens with the power, which is maybe something we should have had today so that we didn't get shut down 2 or 3 times. Not bitter about it whatsoever. Something else that we've heard a lot of you ask about, and some of you may have already been putting into place, is using emergency medical services personnel or paramedics in a hospital setting. There was a bill passed, Act 2021-303, that created a community paramedicine program, which is probably interesting to you. More interesting to you, though, is the fact that it changed the definition of emergency medical services to allow in-hospital care to be provided by paramedics or emergency medical services personnel. A little bit more on that in just a second, but the community paramedicine program is kind of interesting. We're still waiting on rules to come out from the Department of Public Health about this, but it allows basically some wraparound care for patients who are discharged from a hospital or other definitive care facility and are not eligible for or decline home health care services or hospice services. Basically, we're trying to keep them out of the hospital and in the community. And if you've got a referral of the patient to a community paramedicine program to receive services, then you can have emergency medical services personnel providing care coordination, chronic condition monitoring and education, health assessments, discharge follow-up, lab specimen collection, and medication compliance. So this is a new thing for EMS providers, and maybe an opportunity for hospitals to partner with EMS providers, especially in areas where you've got a shortage of personnel to provide these services, to make sure that we're providing, I guess, that full continuum of care for patients. Jumping back to this change in definition of emergency medical services, historically, this has been limited by definition to care provided in a pre-hospital setting, but this act changed it to remove that requirement and allow a continuation, and I'm going to emphasize the word continuation, of care in a definitive care facility, such as a hospital, subject to facility approval and integration of care under the oversight of a medical director. As I read the act, I don't have the exact language up here for everyone, but as I read the act, it's not as if you can swap out a paramedic or another emergency medical service provider for an RN or a nurse practitioner in your hospital. This has got to be I guess, again, a continuum of care where the paramedic brings in the patient and follows them through the course of care while they're at the hospital, not, I guess, kind of freestanding PRN paramedics coming in and subbing out for your nursing staff. Again, this is also pending rules from public health, so we'll wait to see exactly what the requirements are for this, but I'll note, again, that concept of continuum of care, facility approval, and then under the oversight of a medical director, who I believe is going to have some basic training as far as the oversight and medical direction of these EMS personnel. Again, rules forthcoming on that, but at least under the statute, you've got some flexibility to make a more expanded use of paramedics and other EMS personnel than you could in the past. Request for survey suspension. We've seen some letters from the Centers for Medicare and Medicaid Services to the president of the American Hospital Association about a process and some criteria for requesting temporary suspension of survey activity. So again, if you're in your survey window, sorry for that going on in addition to everything else, but there is a process in place for you to request a temporary suspension of survey activity for your facility to the extent it has not already started. So if you've got surveyors showing up, at your facility, once they show up, you cannot ask for a suspension of survey activity. You've got to go through with it. But if they have not showed up yet, you're in your survey window, you can ask for a pause or a suspension in your survey activity based on the characteristics of your hospital and what you're dealing with COVID-19, because we know that adding a survey or joint commission on top of everything else you're dealing with, it's not just an administrative nightmare, it's probably just not unworkable. It's not workable. Not a whole lot of feedback after people have applied for these survey suspensions, but I'll also note that probably the Joint Commission, Public Health, and others. This is not at the top of their list. A lot of them are responding to complaint surveys, complaints, immediate jeopardy type situations, and that kind of thing. That's where they're placing their priorities right now. Otherwise, I imagine they don't really want to be in a facility where they've got infection control not issues, but the possibility of being exposed to COVID while they're in a facility. I'm going to skip right over the immunity protections for right now, outside of noting that Greg, I think, is going to cover some of those later, and that there are already some legal challenges to the governor's emergency proclamation from last year that had immunity protections, and to the liability bill that was passed earlier this year. Some of these pertain to the definition of gross negligence, and it essentially being the same as negligence under Alabama law, but gross negligence is not something you can waive under the Alabama Emergency Management Act, as the plaintiffs contend. There's also questions about the applicability of the Alabama Medical Liability Act to and its heightened pleading requirements in cases where maybe someone who is not a patient was exposed to COVID-19, and whether or not the heightened pleading requirements apply to those non-patients. So I think that'll be an interesting definitional argument moving forward. And then there's also constitutional arguments about the breadth and scope of the governor's power under the Alabama Emergency Management Act and the Constitution, and this concept of separation of powers, and whether or not you can provide liability or immunity protections for a cause of action that had already accrued prior to the time that the emergency declaration with its liability protections or the liability bill was passed. So that case is ongoing right now. I think there's a hearing going on in November of this year. That's something we're going to be monitoring. It's kind of on the front end of the challenges to the immunity protections, at least under state law here in Alabama. One other quick note about that, there's also broad immunity protection under the PrEP Act that is in addition to and also supersedes any sort of state causes of action to the extent the PrEP Act applies. So I would keep that tool in your back pocket as well. To the extent you can make the case that you are covered under the PrEP Act, you might also be able to preempt state law in those circumstances. It's another definitional nightmare where you've got definitions within definitions within definitions, and you've got to argue that you met each one of those. But another tool to keep in mind. Hopefully none of you are fighting any of these immunity and liability issues in the future, but to the extent you are, there's some resources available for you. New COVID-19 challenges. I'll probably focus mostly on the vaccine mandates. Again, we've got this great tool here that's been very effective at preventing COVID-19 spread, and also very, very effective at preventing hospitalization. And yet we seem to have this great political battle over it. We've got a federal, announcement from a couple of weeks ago, and executive orders for federal employees and contractors, and forthcoming regulations from OSHA for a new emergency temporary standard, and regulations that I think are going to be condition level regulations for healthcare facilities. This was expanded from a prior announcement that long-term care facilities such as skilled nursing homes were going to be subject to a vaccination mandate. Now that applies to all healthcare facilities that receive Medicare and Medicaid funds. We'll talk about that in just a minute, but that's kind of what's coming down the pike. Under federal law, there's long-standing precedent for vaccine mandates being enforced by state and or local government as kind of a reasonable public safety measure. Obviously, these have been subject to challenge at different times across the year and across the years, and they will be subject to challenge again with the new vaccine mandates that are forthcoming. But general baseline from a federal standpoint, vaccine mandates are okay for public and private entities, probably with some limitations depending on how you implement it, but also subject to exceptions for medical contraindications and religious freedom. That gets complicated when we have a state law that was passed earlier this year, the fondly referred to vaccine passport law, that prohibits a state or local government entity from issuing or requiring a vaccine passport or other standard vaccination documentation, or requiring people to share immunization records or other quote-unquote similar health information, which is not defined. It also prohibits government entities or agencies from requiring immunization or presentation of immunization documentation in order to receive a government service or enter a government building. I noted up at the top there that state or local government entity or agency is not defined. For those of you that have a useful healthcare authority, healthcare organizational structure, and a lot of times we're arguing that healthcare authorities are political subdivisions and therefore they're not subject to OSHA requirements, or they're entitled to some level of immunity or liability protection under state law. Well, that may cut against healthcare authorities in this case, if to the extent they are determined state or local government entities or agencies that would be subject to these prohibitions under the vaccine passport law. There's also requirements for educational institutions as well that may apply to some of you. And then there's prohibitions on refusing as a business to provide goods or services to a customer based on their immunization status. Note that for private businesses, that does not apply to the employer-employee relationship. As you can see there under some of the Attorney General guidance that we've got from Attorney General Steve Marshall in the last month or two. Unfortunately, I think the Attorney General, he seems to have expanded exactly what is prohibited under the Act. You can see some of the bolded language there. Government entities are inherently prohibited from discriminating against an individual based upon his or her refusal to vaccinate or to present immunization records. Discriminate it's a strong word, it's got a very strong connotation, but on a basic level, it means treat differently. So if you're doing a premium surcharge for an employee, for instance, and you're causing them to pay more for their health insurance coverage if they're unvaccinated, that's treating that employee differently, arguably. And if you fit into one of the categories under the bill, might be prohibited under the statute and subject to challenge. Any sort of different treatment or disparate treatment of individuals based on their vaccination status is now called into question under the Attorney General's guidance. As I mentioned, we've got federal vaccine mandates coming soon, I guess, for executive employees and government contractors. They're already here now under President Biden's executive orders from a couple of weeks ago. I've had several questions from people about what healthcare facilities and businesses should be doing right now and whether they've got to start laying off or furloughing employees as of October if those employees are not vaccinated. Everyone pump the brakes on that. We do not have a rule yet for the healthcare facility vaccination mandate or the OSHA emergency temporary standard vaccination mandate. What we've got is some general indication of what those rules might look like. And that, other than that, we've just got to wait and see what the rules look like. One thing to note is that these rules will be effective immediately upon their publication. They're going to be interim final rules with comment period. So healthcare facilities and businesses are going to have the opportunity to comment on this, just not before the rule goes into place. I've got a lot of questions about how both of these upcoming rules are going to be implemented. I mean, on the ETS side of things for large employers, there's an alternative to allow weekly testing of the employee for COVID-19 as opposed to a vaccination mandate. I've got a question about whether or not that's going to apply for healthcare facilities. Something tells me I don't think so, but that's potentially an option. You've got questions about who's going to pay for the vaccines and who's going to pay for testing if somebody gets tested on a weekly basis instead of receiving the vaccine. There is some speculation that the emergency temporary standards may include protections for employees. Again, this is under the OSHA large employer standards. Protections for employees from unvaccinated customers and third-party vendors. Can't wait to see what that looks like. Not to mention the administrative requirements for documenting everything that you're doing to implement these rules. All this coming from well, at least part of it on the OSHA side, coming from a beleaguered and fairly small agency that we'll see if they're up to the task of implementing a rule with this broad of scope. But again, remember, nothing to be done right now. We're monitoring these rules for when they come out. You don't need to do anything until they come out and we have an idea of what exactly it is that you're supposed to be doing. But I'll note that these federal mandates are going to create an interesting environment when you throw them up against the state vaccine passport law. And maybe even, we've seen a bill introduced by a couple of state representatives that would create a private right of action for individuals who are injured by a vaccine that was mandated by their employer. So you may have a federal law that requires vaccines that does not quite preempt this private right of action, but then you've got an employee that was forced to get a vaccine under the federal standard and then has a private right of action against you for requiring them to be vaccinated. That bill has just been pre-filed. We haven't seen any movement on it yet, but we are watching things as the legislature goes into a special session to address prisons and another one for redistricting toward later this year. There's some heightened requirements for them to go outside the scope of the call for why, I guess, the purpose for why they're there, but it's a fairly low bar. And if they wanted to take up some vaccine mandate issues, I'm sure they will feel free to do so. So we'll be keeping tabs on that. We're going to skip over visitation rights because the bill itself basically defers to federal standards and federal guidance. It's just one more thing to be on the lookout for as somebody potentially challenging you in prohibiting them or restricting their ability to visit a patient in the facility. So keep tabs on that and just know that that's out there. There's the bill itself, Act 2021-470. Again, defers to federal standards, so maybe not that big of an impact, but something to look out for. Last but not least, as we finish up this marathon with only a couple of interruptions, John mentioned the Provider Relief Fund reporting earlier. You can see here, we're looking at somewhere in excess of 120 billion. I think I like John, did not go to law school to do math, but it's in excess of 120 billion in funds just under the general and targeted distributions under the CARES Act. And that's part of, a larger $5 trillion worth of COVID-19 relief money that was passed last year, which, as the Principal Deputy Inspector General pointed out last week, was more than the entire 2019 federal spending budget. Needless to say, they're going to be on the lookout for how these funds were used and whether or not providers who receive these funds complied with all applicable requirements for use of the funds and reporting with respect to those funds. And that's especially challenging because, you were given the funds or received the funds. You may not have even applied for them last year for some of those tranches of CARES Act funding. You received the funds, you're required to attest to them. And then after you attested to the funds, then HHS sent out a notice about post-payment reporting requirements that has continued to change the terms of what you're required to do if you're a recipient of those funds up to as recently as June of this year. A couple of notes about the reporting requirements, which are coming up. I'll show you a slide with a chart on the reporting requirements in just a second. If you're in the general distribution funds, so first of all, let's back up. Anyone who received more than $10,000, you've got to meet these reporting requirements. I think probably everyone on the call, their facility received more than $10,000 easily, probably received that with the first general fund distribution. But anyway, we're talking about general fund distributions. We're talking about complex organizational structures with parent-subsidiary relationships. A parent can report for its subsidiaries regardless of whether the subsidiary directly received the general fund distribution or the parent did, and regardless of whether the parent or the subsidiary attested to the terms and conditions. We get to targeted distributions, you completely reverse that. Only the direct recipient of the targeted distribution can report on it, regardless of whether or not they transferred it up to a parent or down to a subsidiary. And there's also a note in the HRSA audit and reporting guidelines that a transfer of targeted distribution payments increases the likelihood of a HRSA audit. So good news, if you've got one of those corporate structures and you have transfer targeted distributions, you should definitely expect an audit and be prepared to fully document how those funds were used and to what purpose they were put in response to COVID-19 pandemic. Something John, I think, touched on a little bit earlier is that there were so many funding opportunities available from different areas like the PPP program, the CARES Act Provider Relief Fund. There was a state coronavirus provider relief fund, and all of these programs include a requirement that payments can only be used for eligible expenses and that you can't double dip. So there's going to be some serious looking into how funds from these different programs were used and making sure that funds were not claimed under multiple programs for the same expenditures. And in fact, again, in comments from one of the OIG officials just a week ago, I think the OIG is setting up, in conjunction with other federal departments and agencies, a pandemic response accountability committee or commission that is going to coordinate looking at all of these different funding sources available for COVID-19 relief and make sure that again, no one is double dipping, and they're going to be looking at that on a coordinated basis. Last but not least, we're coming up on the deadline already for the first reporting window. So if you received a CARES Act payment between April and June of last year, you had to use those funds by June 30th of this year, and your reporting window is supposed to end on September 30th. There's already been an announcement that there will be a 60-day grace period. HRSA was pretty careful to note that you are still late, but they will exercise enforcement discretion to the extent you are reporting after September 30th, but before November 30th. That does not mean you have a 60-day extension to use those funds. They still had to be used prior to June 30th, 2021. And then there's another note that any funds that were unused from that first, period one tranche of funds have to be returned by the end of the applicable reporting period, 30 days after the end of the applicable reporting period, which as extended is now December 30th of this year. That's a lot to process. It's probably not half of what we could have talked about. And again, apologies for the interruption, but thank you for bearing with us.